sort of topics, and we had some great sort of experts joining this. How to choose anotropes, PDA, when to treat, and management of critical congenital heart disease was managed and very extensively discussed. But as a neonatologist, we always, all the young neonatologists were grooming up, and for all of us who have got trained, I think it has become very important for us to learn this new skill. And I won't say any more new because this has been there for now, some time now, is assess the child clinical on bedside. So one is functional echocardiogram. A lot of time, I think the earlier part of our training, we used to wait for a cardiologist to come and then sort of tell us what is happening. But nowadays, most of the assessment we can do as a neonatologist and then probably confirm when the cardiologist comes. And also our fluid management, our anotrope management, whether we should give food bolus or not, so many things we can do. And that is the reason why it has become an important tool for all of us to know. And so is point of care ultrasound. So, right from assessing your lungs, to assessing your brain, to abdomen, so many things as a clinicians we should know. At what was the radiologist domain, I think neonatologists also need to learn. Whoever is managing critical care needs to have this knowledge. And we have two very important members who are giving lectures on this, and they have been the flag bearers for promoting this in the country. We have Dr. Pradeep Surenshi, who is the head of the department and the director from Bharati Vidyapeeth. He sort of heads so many other units in Pune. But most importantly, all of us know him as the man who has aggressively promoted functional echocardiography, done so many workshops, trained so many people. He also runs an active training program. And along with it, there's none other, the very popular Dr. Mohit Sahni, who's from Nirmal Hospital, Surat, who's the director and head of Department of Neonatology there. And who's again, also is the main editor of the Journal of Neonatology. But he's again has very passionate about functional echocardiography. Together, both of them have conducted many courses, and even during this pandemic time, they have conducted a lot of web-based courses. And we're very fortunate to have them on the NOEL platform today to train so many of our young colleagues and give them an insight into it. And see, this 1.5 hours is not going to be enough for us to, but this is going to be enough for us to at least stimulate to know what is going to be done, and then maybe attend some workshops to get a little bit more insight. And at the end of the day, unless you start practicing, it is not going to be there. Without wasting much time, may I ask Dr. Mohit Sahni to please start his session on the functional echocardiogram. Over to you, Dr. Mohit.
Thank you, sir. Thank you very much. I would like to thank NNF and mainly Dr. Dinesh sir and Dr. Manoj sir for starting this very nice program of NOEL under the flagship of NNF. This is a very important program, I think so, especially for our fellows. So that's why, like, I think so, I have been talking on this functional echo a lot many times, but this time I just thought it should be concentrated just from the perspective of a neonatal trainee, the fellowship people who have been getting trained into the fellowship. I hope everybody can see my slides, sir.
Yes.
Sure.
Yeah, Mohit, we can hear you and see you.
Sure. Thank you, sir. So in this slide, this is why, like, this thing is basically is depicting, like, I will be talking about, because this functional echo is not just for the talk or just for your practical training. It has been asked as a theory question in previous year questions also. So we will be discussing that how the fellowship people who have been getting trained should write the answer for this question of functional echo. And this is depicting your principles behind your uh, echo, like, what are the principles behind when we do the functional echo, and this is for your practical aspect, for your practical training. So this I would like to cover all these three things in next 45 minutes or so. So this is, I am showing, this is the survey I did along with under the guidance of Dr. Patrick McNamara in 3 of Australia, New Zealand, Canada, and India. And what we found during that time, now the things must have changed, that in Australia, New Zealand, maximum echoes in NICU was being done by the neonatologist. In Canada, they were being done by and along with in India also, they were being done by pediatric cardiologists. Now the things have changed even in Canada and US. And in India at that time, the others were the adult cardiologists because of the limited number of pediatric cardiologists they were available. But now more and more people have learned over the years. I think now again we should do this survey, and India will. I hope the India would be in this category. So to learn your functional echoes, you should not consider yourself or think that you should become a Superman. Even if you become a Superman, the Superman has got his own limitations also. So we should think about that also. So don't think that for functional echo you have to be a Superman or Superwoman. So what is our plan of the day? How we will cover up these this session? So first, because this functional echo has been asked as a question in our theoretical question papers also. So we will just see if somebody asks if there is a question on functional echo, how we should write the answer for that. In on Viva wise tables also, there have been questions asked by the fellows. So how to answer those questions? What are those questions can be? Then we will talk about how we can use these practical views in our practical day-to-day care of NICU. Okay, so we will just see what are the basic views in the functional echoes. And then a touch on that how this functional echo can guide us for the proper treatment and how it affects our outcome of our newborns who are under treatment in NICU. So first thing, like I have gone through few last 5 to 10 years question paper of NNF and IAP fellowship exams. So commonly, this is how I've just summarized the questions which have commonly been asked as what is the role of functional echo in NICU practice? What are the various modes of echo? Okay, in how and what are the principles of functional echo? So these are the questions which have already been asked in last few years question paper. Okay, so and we will also talk about some of the resources, and I will try to give you the headings that under how, like it is just a blueprint, it's just a guide that this is how you can write your answers if these questions are asked again in the future exams. What can be the probable questions? The probable questions can be asked as what are the uses of functional echo in NICU? What are the various views in NICU, in neonatology, in echo? How you correlate the functional echo findings to treat if you have a hemodynamic significant PDA or severe PPHN or baby in resistant shock. What are the various principles of functional echo? What is the role of functional echo in NICU management? And this question, I think so, will come someday or other that what is the PAC PNDT Act and what is its relevance in NICU setup if the NICU setup question is being asked. So, like if somebody asks the questions of this functional echo, what is the role of your functional echo? The first and foremost thing is you need to define what is functional echo. We'll talk about this definition, explain it in short, give the scientific evidence. Next thing comes who can perform it. Write the eligibility criteria, like what are the minimum echoes you need to do, what the trainees should go through, just a bit of with reference and bit of explanation for that. And then what are the indications to do the functional echo? Like if you have scenarios like baby with you think it may be a PDA, then or if you are treating a PDA, that how you monitor this. So what are the indications and what are the limitations? The main limitation is if you have some structural issues, you should always involve your pediatric cardiologist. Just don't sit on it. And then the main crux come. What are the principles behind this echo? What are the different views involved in your functional echoes? And what are the different modes in functional? These two questions have already been asked. And then you can write and especially write and depict in flowchart diagrams that what are the different etiologies and how the functional echo affect the and benefits the outcome in those particular pathologies like HSPDA or PPHN or the babies in shock. So to define, like this has been taken very nicely been explained in this. You can download and see this Journal of Parentology, this article in 2011, in which Dr. Afif has defined this functional echoes very nicely. What is functional echo? This is nothing but a point of care focused ultrasound for the evaluation of cardiovascular system. It is nothing but another tool in the hands of a neonatal ICU intensivist to treat the babies. So it is in addition to your clinical judgment. It is not the replacement for your clinical equipment. It is just to support and in addition of your clinical judgment. Therefore, it provides a better understanding of the physiology, what is happening behind that particular pathology. And hence, once you have done the treatment, it helps you to monitor the response to that treatment. So this approach, what it does, it combines both clinical examination and echo, has shown the improved outcome. One, why the outcome has improved? Because you can monitor the treatment you have given. Other thing is you can further pinpoint the clinical diagnosis. Therefore, the outcome of the patient improves. So this is how you can put this thing you can put under the heading of your short description or definition of functional echoes. This is a landmark paper. You should always have this paper if you are writing something about functional echoes, in which they have recent, like their nomenclature it at TN echoes, target neonatal echoes, published in Journal of American Society of Echocardiography in 2011 again. So these two papers are very good papers. You should read through. And then what it does, if you have a clinical problem, evaluate functional for the functional issues. If it is a hemodynamic problem, take some medical decision and then you can revisit it. But if it's an anatomical problem, it's always good to consult a pediatric cardiologist. That is very important. So this flowchart you can depict in your exams. Then the other thing was that who can do it. Now we are planning for a program in India, but there are already established program in Australia and Canada. Okay, in Australia they call it CCPU, and in Canada they call it TN echoes. The duration of training is 1 year to 3 years, 6 months to 1 year. Okay, these are number of images, like, so you can mention these things, couple of these things in under that heading. So what are the indications for doing a functional echo? So these are the most common pathologies which we currently normally see in our NICUs. Okay, so one is PDA. Clinically, if you think it is HSPDA, so any baby you are going to treat for the PDA ideally should have one echo done to rule out any duct dependent lesion before closing that duct. Okay, and then nowadays we talk about HSPDA and PDA monitoring. You have been treating that PDA, or if you're leaving that PDA, it is borderline. You keep on monitor and do echo for that baby, so that once it becomes hemodynamic significant, you can start the treatment before the baby presents clinically. Then the next indication can be the PPHN. Okay, then by doing an echo, you can label what is the severity of PPHN, and whatever baby, whatever the issue is, if you are going to start nitric oxide, it is always good to have one echo before starting the nitric oxide, and then you can even monitor. For babies in shock, okay, the baby is on two or more inotropes, or needing higher doses of inotrope, or babies in resistant shock, that can be an indication for doing in functional echoes. If your baby is on TPN with central line suddenly collapse, you need Dr. Suryavanshi will talk about this regarding this point of care, or there is a baby who is very stable, suddenly becomes sick and collapse. You need to rule out what is happening with the cardiovascular system. So these are the few indications for you're doing functional echocardiography. What is the limitation again? Any structural issues, or if you doubt that something is abnormal, it doesn't look seems to be normal, it's always good to involve your pediatric cardiologist for that. So let's talk about one scenario. This is 29-weeker premature infant around 1 kg weight, given one dose of surfactant, admitted in level 3 NICU, started having increased oxygen requirement, and became hypotensive at 12 hours of life. The only positive history is that the mother had a leaking for around 20 hours and she is already on antibiotics. As you can see, after the admission in the next 26 hours, the blood pressure, normally what we do is we always corresponds the mean blood pressure to the gestational age of the baby. Actually, it is not right, but we take that. Okay, initially the blood pressure was fine. The pH was 7.23 minus 7. It was the base excess. The baby was on minimal ventilatory settings, around FiO to 21%. Then the baby was extubated also, but started having hypotension. This you can see, the mean blood pressures were low, becoming tachycardic, acidotic, base deficit increased, lactate is increasing. We was started on dopamine of 7.5. Okay, even then the persistent hypotension, dopamine was increased, and then dobutamine was added. So this is what, as per our flow chart, treatment flow chart, we keep on increasing, we add on dopamine, keep on increasing the dose of dopamine and then dobutamine. But the baby persistently had low blood pressures, mean low blood pressure. This is what we have seen, okay, and becoming acidotic. So this baby is doing fine? No, this baby is not doing fine. Everybody must be thinking that, okay. So what are the issues and what the next investigation we should plan? This baby is hypotensive. I think everybody will agree. So what is the next thing we should do? The first one thing is we should never forget our basics. Okay, we should always ask to for the exercise. The baby is on positive pressure ventilation is always good practice. If your baby is becoming hypotensive, always rule out and approach as dope. Rule out pneumothorax, rule out any obstructions and all those things. Once it is being ruled out, everything is fine. Okay, okay, start the treatment, and then you should ask for the and do the functional echo. When the echo was being done, now this we will talk about this view also. So this is nothing but a PDA, this red thing, and it is pure left to right shunting. So there was a HS PDA. So this we could have picked up from the clinical this thing also, could have given us a hint. If you see these blood pressures, you could appreciate the white pulse pressure in this. Okay, so there is a white pulse pressure. So that was one of the indication that the baby is becoming acidotic, increased oxygen requirement, and there is a white pulse pressure. So that was giving a hint that this baby may have getting going towards the HS, hemodynamic significant PDA. So this is nothing as you ventilate the babies in your units even if you don't have ventilatory graphics. Okay, similarly you will treat the babies with the shock even though you don't have your functional echoes. But what it does nothing but optimize your hemodynamics as the ventilatory graphics optimize your ventilation. So this is just an add-on. So this was regarding the theory. Like we will talk about the principles and modes and views, but I tried to give you a skeletal out view, like guideline that this is under which headings what all you can write in your theory exams. So what can be the probable questions in your viva on the table? Most commonly, they will it is being asked that do you have echo machine in your units? If you have it, say yes. If you don't, say no. Don't lie in that part. And if you have, whether you have used it or not, you should be very truthful about that. If you have, because otherwise people will keep on asking. Okay. Then one you should know, we will talk about this probe thing also, that which frequency probe is used in preterm infant for the echo. And what are the different views? Just in nutshell, we will talk about that. And some may ask that how you will define hemodynamic significant PDA, okay, and when you treat the PDA. These are the few very commonly asked questions in your Viva voice. So transducer is nothing but the probe, what we call in the echo machine. So one thing we should remember that higher is the frequency, okay. So lesser is the penetration, but better is the resolution. So we use higher frequency probe in the premature babies, and in term and bigger babies we use lower frequency probe because it has got better penetration. So you can see the structures were much deep, but it has got lesser resolution. Okay, the probes they range. Okay, they range from 1 hertz to 12 hertz, now even to the 15 hertz. Okay, in neonates we use mostly 6 to 12 hertz probe. In term, for echo we use 6 to 8, and for head ultrasound 8 to 10 hertz probe. For preterm or low birth weight we use 8 to 10, and for very small babies less than 700 grams the probe is 8 to 10 to 12 hertz probe, gives a better good optimized image because it has got better resolution, and we know don't need the depth because the structures are not very deep in very small babies. This is how you should answer that question. So regarding the basic views, there are different views on the baby's so there are different views on the baby's chest. So we have different windows to get these views. So views are like when we start with the apex, apical 4-chamber view, 5-chamber view. Then we have parasternal views. In parasternal views, we divide it in two: low parasternal views, high parasternal views. Low parasternal views are line joining the nipple lines at that and below. So most commonly used low parasternal views are parasternal long axis view and parasternal short axis view. And then we have high parasternal views, that is from the line joining the nipples above. Okay, in that the commonly views are ductal view, pulmonary artery view, pulmonary vein view, SVC superior vena cava view, and then suprasternal views. Suprasternal view is for the arch of the aorta. And then comes the, like in adults and pediatric, they start with the subcostal. Neonatology, we end up with the subcostal views. So in the end is the subcostal views. That is the, when we put the probe in the subcostal region, that is below the Ziphi sternum. So this is how we classify our views. Why I'm showing this slide? This is for the practical point of view. Whatever machine you have, the main functionality is same. The buttons may be different, so you should not be worried about that. This, we don't have this type of machine or that type of machine. Okay, and this is your basic echocardiographic window. So what it is showing, it is a basic echocardiography window, and this is the probe. What the probe? This is a echo probe. This is a phased array probe. So what we call it also as a sectoral probe. So in this sector, you see this is your probe orientation marker. Okay, and this is what is optimized view. Optimized view is if the structure of the heart covers around 60 70% of the sector, it is adequate. It is considered to be optimized. Okay, and then ideally all the echo machines should be hooked up to the monitor with the ECG leads to get the ECG. This is just, but this is for the advanced this thing. If you don't have, you don't do it, it's fine. Okay, then this is the image I just talked about. So this is your heart. This is your Doppler scale. This is to show that which organ you are doing the Dopplers. Like you, this your scale should be optimized to the particular structure you are doing the Dopplers for. If you are doing the Dopplers for arterial structure like aorta or something, okay, then your range is higher. But if you are doing Dopplers for the pulmonary artery, pulmonary veins or something, so that is a venous flow. So your Doppler scale should minimize, should be less. Otherwise, you won't be able to pick the blood flow in that vessel. These are the color Dopplers. We will talk about these different modes also. So these are the color Doppler. Okay, this is to see the flow of the blood across the valve or through the vessel. And this is your probe orientation marker. This probe orientation marker basically is nothing. By convention, it is always being kept on the left side of the screen in cardiology, and in a radiology, it is always on the right side of your screen. Okay, don't consider your right and left, consider the right and left of the screen. So in cardiology, by convention, this probe orientation marker is always on the left side of the screen. In radiology, it is always on the right side of the screen. It can move up and down, but it always remains on the left side of the screen. Okay, so this is just to give you the idea of the side of the particular structure you are doing. And like if I'm talking about heart, so it is for you to indicate that what side of chamber, which chamber you are seeing, whether it is RARV, LALV, so like that. But it has to be always on the left side of the screen. So there are different buttons on the screen. Okay, different modes of there. One is to increase and decrease the depth, bring the structure in near to you, or push the structure away from you. Adjust the gain, and then the color, and then the different modes. These are the modes. Okay, M mode. M mode is a motion mode. Okay, what it does, M mode calculates the motion of the heart. Hence, it will be useful to measure the various structures of the heart and the functions. Like when we say functions, the most common parameter we use to measure the functions of the left ventricle is FS, fraction shortening. It tells you the contractility of the left ventricle. Then pulse wave, pulse wave Dopplers. Pulse wave Dopplers are to measure the flow of the blood through the vessels or across the valves. Continuous wave Dopplers. I will talk about the difference between pulse wave and continuous continuous wave. And then in color, we will talk about that why we see the color as blue and red. Okay. So this is how these buttons can be helpful. So let's talk about what is the pulse wave Doppler, what is a continuous wave Doppler. As you can see in this, so there is a gate like this. There is no gate, anything like that. So what happens when we put pulse wave Doppler in the flow of the while to measure the flow of the blood in a vessel? So what it does, it will measure the flow of the RBCs on the blood only within this sector. It will ignore the velocity of the RBCs above and below. So what you can do is very small range, you can measure the velocity of those blood. But the downfall for this is anything which is more than 2 meters per second, it cannot measure. Therefore, whenever there is a stenotic lesion or regurgitant lesion, it is always good when you are getting flow velocities of more than 2 meters per second, switch over to continuous wave. What continuous wave does, it measures the velocity of all the RBCs along this sector and it will give you the average. So you can measure the velocity even more than 2 meters per second. So this is the basic difference between your pulse wave Doppler and the continuous wave Doppler. Then when we were talking about in our that basic echo screen, that this is a probe orientation marker. How does it correlate with probe orientation, probe marker? So the thing is, when we will talk about various views, I will go through this. But one thing you should remember that this probe marker, it always correlate with the probe orientation marker on the screen. This is one thing you should remember. And when we talk about the color, so it is never that it is a venous blood or arterial blood. Whenever the blood is moving towards the probe, it is by convention. You can even make it green or blue, you pink or yellow, whatever you want. But by convention, it is being kept like that. The blood flowing, moving towards the probe is red. Blood moving away from the probe is blue. And when there is a turbulence, it looks orange or yellow. So if you want to remember, you can remember by easy mnemonic BART, blue away, red towards. So this is the significance of blue and red when we put the color Dopplers. So now, practical issues. If you have a machine in your unit, you should start doing the echoes. Wherever you want to keep the probe, you keep the probe, but start doing it. This is just to give you the guide that when we talk about apical views, apical 4-chamber and 5-chamber views, the window is apical window. It is just below your nipple, at the nipple line. This is your apical window. Next is for the parasternal views. Okay, it is just at the nipple line. Okay, at that area, just left or above the sternum. For high parasternal, it is just subclavicular, left subclavicular. Suprasternal notch, already this is anatomical point of view. So this is just from suprasternal notch. In subcostal, it is just below the xiphisternum, in between the line joining xiphisternum and your umbilicus. So these are the windows for various views. Whenever you are doing an echo, it's always good practice. Instead of learning it where you keep the probe marker, right side, left side, it's always good practice to imagine a clock in front of your baby. Okay, so this is 12 o'clock, 6 o'clock, 3 o'clock, that is left, 9 o'clock, that is right. This is how you can remember. Okay, and you should learn how to optimize your view. That is very important. So when we talk about the basic views, first thing is 2D view. This is how you will see. This is your 2D view. This is how it will look in gray and black. Then comes the Dopplers, color Dopplers. You put a color window on that, you start seeing the flow in the vessel or across your valves. And then comes third mode is the M mode. That is a motion mode. This is I've already talked. This is to be used to calculate the contractility and measurements of the various structures of the heart. So let's talk about apical 4-chamber and 5-chamber views. This is very important because by seeing at this, you can just rule out any structural issues. Like if there is hypoplastic right heart or left heart, you can instantly will see. Just by seeing the motion of contractility, you can make a idea just by eyeing the contractility of the heart. You will make idea whether it is contracting less or more. Like if you have a baby who is preterm, we talked about that baby, second day or third day of life. Mostly what happens is Normally at that day of life, right side is our predominant. But if your baby is having HSPDA, hemodynamic significant PDA, your LA-LV will be volume overloaded. And in Apical 4-chamber view, you will see, okay, this is a preterm baby, 1.2 kg, second day of life, left-sided are bigger than your right side. That shows there may be a HSPDA. In pulmonary hypertension, your RA-RV will be dead. So a Apical 4-chamber view can give a lot of information. You can rule out some basic gross structural anomalies. If the baby is having in shock and there is intracardiac volume is less, so your heart will be shrunken. It will be less. The volume you can judge. You can judge the contractility of the heart. You can rule out any fluid, pericardial effusion. So this view is very important then. So this is how you do it. This is your baby. Okay. The pointer is pointing at 2 to 3 o'clock position at the apical window. And this is what you will see. What we have done is we have kept this pointer probe orientation marker down. This is an upright view of your heart. This is not inverted. So this is, as you can see, the point marker is on the left side, 2 to 3 o'clock position. So these are your LA, LV, RA, RV, interventricular septum, interatrial septum, and 1, 2, and 3. These three are the your pulmonary veins. So this is a apical 4-chamber, 5-chamber, 4-chamber view. Okay, in the similar position, you just rotate this marker probe by clockwise. From 2 o'clock, you rotate it to the 3 o'clock and slightly sweep the probe upwards. What happens is this fifth chamber opens up. What is this fifth chamber? This is your aorta and this is your aortic valve. This is mainly used to measure the velocity of the blood flowing through this aorta. That is your LVOT, left ventricular outflow tract, in order to calculate your LVI or left ventricular output. Because this is your apical 5-chamber view. So what we have seen is probe at apical window, you see apical 4-chamber and apical 5-chamber views. Okay, so what is happening? This is how. Imagine your ultrasound waves are nothing but a knife. Okay, so this is what it is showing. This animation is showing. This is the knife. So what it is doing, it is cutting your heart from the middle and is bringing it up on your screen. And this is our apical 4-chamber view, LALV, RARV. This is how it is doing. Okay, see. So this is basically an adult animation. So that's why they have shown it upside down. In neonatology, we keep it anatomically corrected. So this is basically nothing. Again, the same thing. LALV, RARV. So imagine that this is apple which is being cut upside down. So when we do the Dopplers, put a color Doppler on this, what we do is we are seeing the flow across the tricuspid valve, mitral valve, and blood flowing through the various vessels like, aorta. And then if we sweep up the pulmonary artery. So this is your Dopplers, which has been seen done through the tricuspid valve. Red flow is the flow from RA to RV. And if you want to see the TR, a blink of TR, you can see this will be blue because your probe is here. So TR is the flow flowing from your RV to RA. So that is away from the probe. That's why it will be blue. Your MR will be, mitral regurgitation will be seen as blue. But flow from your LA or RA towards your ventricles will be seen as red. So, and then this is again a Doppler across your mitral valve in a apical 4-chamber view. So this is a apical 5-chamber view. When you put the Dopplers, this is the flow which is being seen in your aorta. Again, this is blue. Why? Because this is your probe and the blood is flowing away from the probe. So that's why it is blue. Okay. And if in the same position, if you sweep your probe upwards more anteriorly, your aorta, which was like this, it will go. And then at right angle to that, another vessel will appear, and that is pulmonary artery. So that crisscrossing is there. When the probe was down, bit down, you were seeing aorta. And then if you sweep up anteriorly, your aorta is gone, and then in crisscross, you see this pulmonary artery. So it again ruled out one of the very major defect of TGA, that it is a normal relation between aorta and pulmonary artery. If you don't see this crisscross, then then you can doubt TGA in the babies. Okay, this sweep. So that was apical 4-chamber and 5-chamber views. And now next thing is low parasternal views. In low parasternal, first thing is long axis, parasternal long axis view, plaques view, what we call. So it is again at the nipple line. You again, all these views are divided in 3 modes: 2D, Doppler, M mode. So you have to just learn and write down in the exams also like this. So this is, now the pointer is pointing at 11 o'clock position towards the right shoulder at the nipple line. Now you can see the probe orientation marker is up. So only for this apical 4-chamber and 5-chamber, we keep this probe orientation marker down. For rest, it is up. You see these structures as this is anterior, this is right ventricle, anterior wall, RV, interventricular septum, LV, and posterior wall of LV. So this is how the heart, your heart, what happens to your heart is, this is where your probe is. This is how your rays, ultrasound beams, they are going. Pointer is pointing at 11 o'clock position. Your heart is being cut longitudinally. See, this is how your patient is lying. Your heart is cut longitudinally, and this is how you will look at the heart. This is how your heart is being cut and is being brought up in front of you in your screen. So it is like a banana split. When you put the Dopplers, so you are doing the Dopplers to rule out any ventricoseptal defect here. So if there is ventricoseptal defect and the flow is from left ventricle to right ventricle, it will be towards the probe, it will be red. If it is from right to left, it will be blue. So again, in this, you can do the M mode, this motion mode, okay, and then you can calculate your FS as I have already told. I won't go in detail there. So there are 2 sweeps in this view, parasternal long axis view. One, when you sweep downwards towards the foot, you start seeing the tricuspid valve. Okay, and then when this probe sweep will be upwards towards the head. Okay, this is your normal plaques view. When you sweep upwards, you start seeing this pulmonary artery. Now again in this view you have seen there was in the plaques view there was aorta. When you sweep up anteriorly, okay, your aorta like this aorta is gone and you see at right angle you start seeing pulmonary artery. So again this rule out your TGA. Okay, so this is how you sweep. If you sweep up, that aorta is gone and you start seeing this pulmonary artery. And this is how when you put the color, this is MPA, main pulmonary artery, this is RPA, this is LPA. And when you sweep down towards the foot, you start seeing this tricuspid valve. And here you can measure your TR jets. Then the second part of low parasternal views is short axis view. So that was parasternal long axis view. This is short axis view. This is nothing but cutting the heart cross-sectionally. So you will see that the pointer is being rotated at same point, same thing. The probe is being rotated from 11 o'clock to 1 o'clock position. Probe orientation marker is up there and you start seeing the heart in cross section. So this is the first basal cross section of the heart at the aortic base of the aorta level. So this view we call it Mercedes-Benz sign view. You see these 3 spokes of aortic valve. This is your RA, this is your pulmonary artery, this is RV, pulmonary artery, this is your RA, interatrial septum, and this is your LA. And nowadays, for like when we talk about corona or MISN, when we talk about to calculate the coronary arteries, this is a view to calculate your coronary artery size. These you can see the coronary arteries here. Here you can very well see these coronary arteries. Okay, so now this was apical 4-chamber and this is in cross section like this. You will see this cross section view. So what happens? The heart is being cut cross sectionally, and this is what I have shown you, the Mercedes-Benz sign view. And then we do the sweeps from the base of the heart to the apex of the heart. Okay, so this is nothing but this is how the apple is being cut cross sectionally. And when you sweep down from the base, you will come to the mitral valve. Okay, so this mitral valve is fish mouth view. So you see this LV, interventricular septum, and this is RV. Again, you can do the Dopplers of the interventricular septum to rule out VSTs. And then comes the high parasternal views. This is in the upper 1/3 of the sternum above the nipple line. So what all views we have in that? You can see this. What we say is right subclavicular and left subclavicular. Ductal view, pulmonary artery view, pulmonary vein view. Okay, so these are the three. Left subclavicular. SVC is the right subclavicular view. Then you have suprasternal notch with aortic arch view. Okay, so these are the views which are high parasternal views. Ductal view, you again, I will just show you. The pointer you keep it at left subclavicular area, pointer at 12 to 1 o'clock position, probe orientation marker above. You say this is a modified short axis view. So what you will see is pulmonary artery, and this is descending aorta. When you put a color, you will see these two blues. So this is descending aorta, this is pulmonary artery. PDA is always from the descending aorta goes to the pulmonary artery. So if it is left to right flow pure, it will look red because it is towards the probe. And if it is pure right to left, again it will look blue. And in bidirection, it will look as red and blue. So now you can see there was no PDA and there is a PDA. As you can see a stream of red jet from this descending aorta towards the pulmonary artery. So this is your PDA in the ductal view. Then comes the suprasternal notch view, pointer pointing at 12 to 1 o'clock position, probe orientation marker again up. And this you can see ascending aorta, arch of aorta. These are the three branches, and this is descending aorta. And this is your RPA, right pulmonary artery, because they are both at right angle to each other. And this is how, when you put a color, you can do the Dopplers in the aorta. This is descending aorta. Left subclavicular area like pulmonary artery view and pulmonary vein view. Now the pointer is pointing at 3 o'clock position in the left subclavicular area. This is again probe orientation marker up. This is aorta and this is your pulmonary artery, MPA, RPA, and LPA. This is also known as the pent leg view, pulmonary artery view. And when you keep the probe there at 3 o'clock, sweep downwards. When you sweep downwards, you will see this is LA and the pulmonary veins are entering 1, 2, 3, 4. So this is known as crab view. So it looks like a crab. So this is your crab view or pulmonary vein view. And then comes your subcostal views. So subcostal views are again divided into two, cross-section subcostal views and longitudinal. So this is your cross-sectional. Pointer is pointing at 3 o'clock position. Now again, just for the orientation of the anatomy, I have just brought this probe orientation marker down. So the closer to you is the right atrium. This is your left atrium, RA, LA, and this is interatrial septum, and this is your PF4 AST. And you put a color, you will see again the flow through the PF4 ASD. From right to left, it will be away from the probe, so it will be blue. From left to right, it will be towards the probe, it will be red. And then it is longitudinal subcostal view. The pointer which was pointing at 3 o'clock, now it is pointing at 12 o'clock. If you sweep the probe towards the right side, you will see this IVC below the liver, and this is your hepatic vein. It is entering your RA. And then if you sweep it towards the left side, you will start seeing your abdominal aorta. These are your spinal cord, vertebrae. This is your pulsating vessel. And there are two branches in here, which is celiac and SMA. So these are your subcostal views. So just in summary, if you want to see, like these are the three diseases we commonly see: PDA, PPHN, and shock. These are the different views we have talked about, 4 and 5 chamber views. These are the various measurements we do to signify and quantify these diseases. Long axis, parasternal long axis, parasternal short axis, ductal view, arch view, and subcostal views. This is how we can make a table out of it. So when we talk about the approach, like babies in shock, okay, if you do an approach with the functional echo, you first have to see whether this baby who is off colored or perfusion is poor, whether there is hypotension or no. If there is hypotension, rule out first the high mean airway pressures or pneumothorax. Okay, then go for a functional echo. If there is no hypotension, do a functional echo, calculate for the cardiac output. If the cardiac output is normal, there is no hypotension, do not treat. But if you have low cardiac output, okay, or if you don't have pneumothorax, did a functional echo and there is a low cardiac output, Then you look for contractility of the heart. If the contractility is low, start some inotrope like dobutamine. If there is hypovolemia, give volume. If there is normal or high output, you have to look for the PDA. If the HSPDA, don't start with inotrope, treat the PDA. If there is no PDA, then it may be sepsis with high output failure. You start with the vasopressors like low dose adrenaline or dopamine. So this is how the functional echo will help you. Now there is one paper which has shown that functional echo has made difference in the outcomes and deciding factor. Like in case of PDA, in clinical assessment, they planned when they did an echo, there was change in around 40% in the management. One was they shifted from treating to conservative or medical to conservative management and surgical management. In babies with shock, when they did a functional echo, there was a change in 93% of our management decision. And the major decision, one of the thing was de-escalate the therapy. That was the major one of the, like you were giving, treating that baby with higher inotropes. You have to come down. In pulmonary hypotension, also it was seen when the functional echo was done after the clinical assessment plan, 40% in 40% of babies the decision was changed. So that's how the functional echoes make a difference in your treatment plans. So let's talk about one last scenario. This is 19 days old male born at 30 week, weighing 1.25 kgs with a large HSPD of 3.2 millimeters. Medical treatment failed, was referred for surgical ligation. Okay. There was Acinetobacter sepsis with bilateral IVH. Baby was on high frequency at that time with FiO to 40%. Procedure went uneventful for around 1 hour. Okay. But as you can see, this is post R, post operative number amount time. So initially was doing well, but started having hypotension after a few hours of operation. Was started on dobutamine. Dobutamine increased till 20, but still hypotensive. This small heart shows the echo, functional echo was been done. And after this, you can see there was an increase in the blood pressures. Okay. By this time, the baby was acidotic with increased lactates. So when this echo was done, so it was not the heart which was the culprit. This is what Dr. Suryavanshi will talk about. So there was a pleural effusion after the post-operative thing. So when this thing was been drained, chest drain was inserted, the baby became fine. So just when you do even the functional echoes, don't just concentrate your vision on the heart. Look around also. It is very important. So this is just to show you, this is also you can write how your functional echoes can impact and augment your clinical decisions. Like this is your blood pressure, which you is a clinical parameter. This is your cardiac output, which is your functional echo parameter. So as we have discussed in that flowchart, if you have normal or high blood pressure, normal and cardiac output, you need not do anything. If your blood pressures are low, but your cardiac output is normal or high, so most common reason in preterm is the high volume shunts. You need to treat the shunt. Okay, that is the main thing. If you have normal or high blood pressures, low cardiac output, it means your afterload is high. What you need to do is you need afterload reducing agent and something which augments the contractility. So the thing that is inotrope which that can be useful is dobutamine or milrinone. If you add dopamine in this baby, it will be detrimental. If you have low blood pressures, low cardiac output, so that is a combination shock, combined shock. Most common reason for that is your sepsis, septic shock. So you need to add dopamine, dobutamine, or epinephrine in combination. So that's how it will help in making the decision. So my friends, I know this is rainy season. Okay. So, but the thing is, if you have equipment for the time, try to use it. Don't keep it for future use. Okay. It will not help. Always try to use whatever you have in the unit. So this is the resources. In this, there is a chapter on functional echo. It will help you in writing all kind of answers and give the viva answers in your paper, in your exams. There are chapters regarding cardiac in this book regarding your cardiac ailments and cardiac issues, PDA and congenital heart disease. So these are the two very good textbooks. You will get a lot of material for your exams. Again, this is a paper I have mentioned in American Journal of American Society of Echocardiography, and this is a Skinner. it is very extensive, may not be useful for you in your exams much, but this one particular article written by Dr. Skinner in 1998 again is a very good article. If you read that, that will also help you in preparing your answer for the functional echo. And for your practical and all kind of modes and views, we have this book. Like it gives you all everything about heart, even in the point of care ultrasound also regarding you can get practical knowledge and you can get a lot of material to write in your answers. So thank you very much.
Thank you, Dr. Mohit, for an excellent presentation. You made it very simple for the trainees, and the videos were excellent, the views were excellent. You, I think, give a very practical sort of representation for the trainees about what they should do. I'm sure they need to read more about it and probably attend either online courses or a workshop to actually get a hands-on view. Or I'm sure they have faculties who would be able to actually teach them on a bedside, because that's the best way to learn. I think in the chat box, I just see one question saying, what is the importance of probe orientation? Would you just probably just touch base on that, Mohit? And then probably in the end, we can come back to the question answers for the students if they have.
Sure. So the importance of probe orientation is that, as I told, like there is a probe marker on the probe, and then it corresponds with a probe orientation marker on the screen. So it is just to give you the idea that which side of the heart you are seeing. Like suppose if in apical 4-chamber view, if you have a probe marker which is pointing at 3 o'clock, that is towards the left side, and on the side of probe orientation marker on the screen, if you see the chambers, those are your left sided chambers. And if you rotate the probe by 180 degree from 3 o'clock position to 9 o'clock position, that is from the left side to the right side, and you keep the probe orientation marker same on the screen, then on that side, the chambers which were left sided chambers now will be on right sided chambers. So basically, this is just to give you the orientation of the side of the heart.
Thank you, Mohit. I think what we will do is we'll take some questions towards the end. Is it okay, Mohit? Should we take the questions to end and we'll ask Dr. Pradeep without wasting much time? I think a lot of us now have managed sicker babies with sort of using point of care ultrasound, and how important it is for all of us to know. Off to you to you lecture on point of care ultrasound for neonatologist.
Thank you, Dr. Dinesh.
I request all the participants to please post their questions in question answer box. So at the end of the sessions, we can have a discussion on this.
Is the voice and the screen visible?
Yes, yeah, it's visible.
Okay. So thank you, Dr. Dinesh, and thank you, Dr. Manoj, for this wonderful program which is going on for the fellows and for consultants, for all of us. Now, Dr. Mohit has covered about the functional echo aspect. The next, what I'm going to cover is a point of care neonatal ultrasound. We will cover the basic aspect of the cranial ultrasound, lung ultrasound, gut, and the lines. Few aspect has been covered by the training aspect, but let's see what we are going to think. When we were a medical student, we always learn inspection, palpation, percussion, auscultation. So dear friends, there is no shortcut for these things. Medical school will remain same. These parameters will remain same. The ultrasound has added additional thing, which is we call as insonation. So in future, probably next 3 to 5 years, the ultrasound will come in your curriculum from MBBS, and insonation will act as a fifth pillar of the bedside examination. In neonatology, we day-to-day perform bedside ultrasound, and the machine we actually move from one baby to another baby. And that is how we will see how it is useful. The point of care ultrasound is nothing but it's a focus thing, which is a bedside done by the clinician. We are not cardiologists, we are not radiologists. One of the important things, please remember, any structural problem, please involve cardiologist. Any structural problem, congenital problems involve radiologist. For the point of care, we have some questions in our mind. Does the baby has RDS? Does the baby has pneumonia? Does the baby has a pleural effusion, pericardial effusion, ascites? The answer will be yes or no. That's the actual case of point of care. You get immediate answer and you treat that baby on the basis of your life-saving therapies. So this is a fantastic flow chart for those who want to see that I have a question, which is the focus question in my mind. Then I'm doing the bedside ultrasound, which is a real, which is a serial. I might repeat my ultrasound after 12 hours, after 24 hours, mainly for the purpose of the physiology and functional problems. I then define all these parameters and then I decide treatment on the basis of point of care ultrasound. Once I have given the treatment, I will re-monitor after 12 hours, 24 hours or 48 hours. And this cycle is actually called as a clinician performed ultrasound, point of care ultrasound, or targeted neonatal ultrasound. All these names are been by various societies as they have used day by day practice. This is the most important thing what I want to tell you, that point of care ultrasound is for diagnostic purposes. At the time of critical assessment, when baby suddenly collapsed, when the baby has deteriorated, that time you get immediate help. It is for screening purposes, it is for monitoring, and you also can prognose the baby's condition in some conditions. Definitely point of care ultrasound has taken care for procedure and therapeutic tapping also. But what I want to tell you for the young ones who are attending this workshop or guest lectures by Dr. Mohit, we need to think in future about the research from point of care ultrasound. These are the simple research which are going to help for the Indian setups. And naturally, our own research will help us. I will also show you that the last 5 years, how the research has helped us in day-to-day practice. So this is the proposed point of care ultrasound for the NNF. Last time we discussed. Dr. Mohit has discussed about the functional echo. But the most important components of point of care ultrasounds are cranial ultrasound, lung ultrasound, gut ultrasound is coming in big way. The lines, insertion, confirmation of line position, procedures like simple lumbar puncture, suprapubic tap, pleural tap, pericardial tap, ascitic taps. And just now I mentioned the research as you can measure the Dopplers, you can measure the flows, and you can contribute to the additional components of the research. So this is the whole coverage when we're talking about the point of care ultrasound in neonatology. This section just now covered by Dr. Mohit. The ultrasound mainly for the cranium, it helps for the diagnosis, screening, and monitoring purposes. We will show some of the cases when we'll discuss that one. The lung ultrasound, I think if you open any journal or you just put any index, PubMed or Scopus, anywhere, in 1 month time, you will find 2 to 4 articles on lung ultrasound. 2010-2012, we had 20 to 24 articles, and in 2021, we have 242 articles on lung ultrasound. You can see how the lung ultrasound has picked up in various NICUs. It is useful for whether I'm dealing with RDS or TTN, whether the baby has a pneumothorax, whether the baby has collapsed, any infusion or pneumonia. That's where the lung ultrasound helps. The last 4 years, the gut ultrasound has picked up for mainly for NAC purposes. Thus, there is a bowel wall thickening, bowel wall thinning, decreased perfusion, associated portal vein gas, associated intramural gas, or ascites. These additional things we get from point of care lung ultrasound. When it comes to NICU, we always talks about the lines. That means umbilical artery line, umbilical venous line, endotracheal tube, insertion of PICC lines, the ultrasound helps immediately when you want to confirm the position of lines. You don't have to wait for X-rays. Most of the X-rays takes around 10 to 15 minutes in good NICUs also. Ultrasound bedside is hardly 1 or 5 minutes, and that's the utility of this ultrasound. So let's see the cases. We'll progress these cases and we will involve various types of ultrasound. Again, I will start with a case which you will see again some aspect of the cardiac ultrasound, but we will move from that cardiac because already we discussed few things about cardiac. This is a 34-weeker baby, 1.4 kg. Baby was outborn. Baby has deteriorated on day 4 with apnea, bradycardia, hyperglycemia, high lactate. Baby required ventilation and shifted to the tertiary center. On admission, baby has a severe hypotension, mean blood pressure is 20 for 34 weekers, very problematic. Prolonged capillary fill time, severe acidosis, high lactate. Just now you guys have seen the functional echo. These babies, you can see there is a massive TR with MR with bidirectional PR. So preterm baby with deterioration on day 4, day 5, with high cardiac output, with tricuspid irritation and bidirectional PDA, suggestive of pulmonary hypertension. Now, this is what we documented, and this is the paper our team has published in Journal of Ultrasound in Italian journal, that we found that in the babies of a late onset neonatal sepsis, the pulmonary hypertension is a very common entity. What we found out that in the study group, the babies' pulmonary pressures were above 35. In the control group, we have only 10 to 12. So the babies with the late onset neonatal sepsis are associated in India, mainly gram-negative sepsis, are associated with pulmonary hypertension. If you see the gestation-wise in those babies, mainly the late preterms and the early term and term babies, they have a higher pulmonary hypertension as compared to the more extreme preterm babies. So what is the first thought process came in our mind that the late onset sepsis in India, mainly gram-negative sepsis, the common organisms in our unit are as same thing, Klebsiella, Acinetobacter, E. coli, Enterobacter. These babies have a pulmonary hypertension. We have also measured the cardiac output in these babies, and the cardiac output turned out to be very high. The normal cardiac output in the babies is 150 to 250 ml per kg per minute. Here, the cardiac output in these babies turned out to the 400, 300, 500 ml per kg per minute. So these are the babies with a high cardiac output with a pulmonary hypertension, suggestive of vasodilatory shock. Hence, another study done by our team, measurement of cardiac output in late onset sepsis. And the values came out from 300 to 450 ml per kg per minute, mainly in gram-negative sepsis. So what we concluded from these studies that in Indian setup, with a gram-negative sepsis, we are dealing with a lot of vasodilatory shock. Naturally, what these studies have added to us that we need to think about proper support when we are thinking. What support we are thinking? We are thinking in the form of selection of proper inotropes. So what these studies have shown us that we need to think about the drugs which acts as a vasopressor. And hence, in the last 4 years, we have shifted our studies as norepinephrine as a drug of choice. If there is associated issues related to the dysfunction, then we add dobutamine or milrinone. So the point of care cardiac ultrasound has helped us in selection of inotropes. This baby, we have done the lung ultrasound. This lung ultrasound is a classic of Schrader sign, classic of syn pneumonic. You can see a little bit effusion also, and this is hepatization of lung. So this lung ultrasound has indicated this baby has a pneumonia, bad pneumonias. So this is the classic picture of hepatization with syn pneumonic effusion and Schrader sign of a lung ultrasound, which we'll cover when the lung ultrasound discussion will come. So we saw the cardiac ultrasound. we saw the lung ultrasound, which has helped in diagnosing of the pneumonia plus pneumonic effusion. At the same time, we wanted to do the lumbar puncture. And for that lumbar puncture, simple spine ultrasound has done. The spine ultrasound has helped us to identify the position of the spinal tract, position of L2, L3, and identification of the vessels. So point of care spine ultrasound is useful before doing lumbar puncture to avoid traumatic lumbar puncture. I think you all know interpretation of traumatic lumbar puncture becomes tough. So for this purpose, ultrasound has helped us very well. After doing your lumbar puncture or that time, you have done the brain ultrasound of this baby. This baby shows dilated ventricle, irregular ventricular margin, and you can see the rain dropouts. These rain dropouts are nothing but the cells, and they are indicative of leukocytes inside the ventricles. That means this is a baby of a classic example of ventriculitis. And you can see the dilated ventricles. These are the dilated lateral ventricles, dilated occipital horn of ventricles, temporal horn of ventricle. So this baby has a sepsis-related ventriculitis. This has increased our thought process to monitor the ventricles every weekly for the purpose of future problems. This also helped us in decision of antibiotics duration. So in a 5-minute duration, in a short assessment, we have screened the cardiac ultrasound, we have screened the lung ultrasound, we have done the spine ultrasound, and we have also done the brain ultrasound. What is useful for us, in another case, the brain ultrasound shows this is a Citrobacter or Burkholderia capsicum also, the brain abscess also documented by the brain ultrasound. So it is useful to document these cases by immediately doing the cranial ultrasound. In the sepsis, then one of our fellow has done the documentation of finding about registry index. This registry index in sepsis, what turned out to be absent or reverse flow. This is classic reversed end diastolic flow in anterocerebral artery. So this reversal of end diastolic flow is a worsening prognosis in late onset sepsis. And this was the report published. And then later on, we did a study, observational study about the babies of late onset sepsis and finding the RI in those babies. The normal RI is 0.75 plus minus 0.08. While the babies with the sepsis, we found out absent or reverse. This was observational study, and this study shows that the 50%, 55% of the babies have an abnormal RI. So this is very useful that worsening of the RI has indicated worse prognosis. Those babies who have absent end diastolic flow, their prognosis was slightly better as compared to reverse end diastolic flow. Worsening of reverse end diastolic flow turned out to be the death in those patients. So what it turned out that we could able to prognosticate the baby's condition on the basis of point of care cranial ultrasound. So we have done diagnosis, we have done the monitoring, we have done the screening, we have included the therapeutic window of lumbar puncture, and we have also included the prognostic factor. We also did a small hip ultrasound. This hip ultrasound indicates there is exudate here, and confirmed by your MRI scans that there is a fluid, there is a sinal fluid, or this is nothing but what we are talking here is echogenic material in the hip ultrasound. So there is hip involvement in this baby, along with your cardiac, brain, lung, hip was also involved. Naturally, this baby was intubated, and this intubation was confirmed by endotracheal tube position, confirmed by ultrasound. We all know the arch view, just we saw the arch view. In the arch view, the center there is RPA. Adjacent to this RPA is the carina. And you want to keep your endotracheal tube 1 centimeter above the carina, that's the endotracheal tube. This is the endotracheal tube position. Very easy procedure. You can confirm this endotracheal tube position by ultrasound as the most simplest way. You don't have to wait. You don't have to wait your X-ray. So position confirmation. At the same time, this baby also required the PIC line. And the PIC line confirmation just in the IVC was also done by the subcortical view, which Dr. Mohit had just shown you is the IVC confirmation as the PIC line confirmation in IVC. So you can see the procedure line confirmation by the point of care ultrasound. And this is the study, one more study done by our team, that utility of point of care ultrasound in late onset sepsis. What we found out that by ultrasound, the brain abnormalities was around 50% of the babies. The cardiac abnormalities was around 80% of the babies, functional abnormalities. The lung abnormalities were 30%, and the abdominal abnormalities were 10%. So this is the future for all of us, because in India, still we do struggle with sepsis. And the sepsis and ultrasound goes hand in hand. Hence, we need to work about utility of these ultrasounds in these conditions. So what this case has taught us? This case has taught us that the ultrasound has helped me in finding out which type of shock I'm dealing. That's why I selected some inotropic agents. I told you in the form of noradrenaline or adrenaline, whatever the unit choice you have. And we also helped in lung ultrasound, brain ultrasound, hip ultrasound. And we also able to think about duration of antibiotics, line position, lumbar punctures, and insertion of PIC line, confirmation of line. This is the utility from this case, what the ultrasound can do in the 5 minutes or 10 minutes time. That's very good. Those who are interested, this is the review written by our team, point of care ultrasound in sepsis. You can just, it's a pre-article in Pediatric Infectious Disease Journal. You can download. You will see all the charts related to ultrasound and sepsis. You will get all the information. So that's the article. Now the case number 2. This is a 25-weeker baby, 600 gram from the PSC. And you can see the baby's lung. The lungs white, subpleural pneumonia, white lung on the X-ray, and poor contractility. Naturally, first thing comes in your mind, parents want to do everything. First thing comes to mind that the pale baby looks white out, everybody wants to give surfactant therapy. But when we are talking about 25-weeker outborn 600 gram, immediately this baby's brain ultrasound done. And this baby's brain ultrasound shows massive periventricular hemorrhagic infarction. With this massive periventricular infarction, it becomes very difficult for anybody to continue the future treatment. This ultrasound has helped me in prognostication of this care of this baby. As 25-weeker, outborn 600 gram, we are not keen now to continue the care and not to give surfactant therapy also, explain the parents about the future outcomes, and then take the decision. So this is where utility of cranial ultrasound for the prognostication is very helpful. So the point of care cranial ultrasound is useful for screening of IVH, diagnosis, critical assessment of IVH plus cerebral ultrasound, that is a cerebral hemorrhage, plus subdural hemorrhage. That is very, very important when we think about the IVH. It is also important for post-hemorrhagic hydrocephalus monitoring and measurements. Infection-wise, just I showed you about dilatation, ventriculitis, abscess. The ultrasound is useful. And it's a bedside, it's immediate. Dopplers, they again very important in cases of asphyxia, in cases of hydrocephalus, in cases of AV malformation, and in cases of sepsis, just now we saw. So the point of care cranial ultrasound, this slide will tell you that includes all angles. Just now we learned that we have 4 to 8 probe transducer is useful, sector probe useful for doing the cranial ultrasound. This is the protocol we have written, which is published in Indian Pediatrics in 2016, that the screening protocol. The baby is less than 28 weeks, less than 1 kg. You should screen on day 1, 3, 7, 14, 28 and before discharge. Smaller the baby, more screening. Simple thing, within 24 hours, that means 1, 3, 7, 14, 24, 28, and before discharge. For 28 to 32 weeks, one ultrasound in first week, second week, 4 to 6 weeks or before discharge. There was an issue related to 32 to 34 weeks because Western culture they don't do. For Indian setup, that's what we did a study, and we saw that in Indian babies with a low Apgar score, with ventilated babies and with the sepsis, they have almost 30% of the morbidity, 30% of ultrasound problems. And hence, we say that if you have risk factors like a twins, microcephaly, ventilation, surfactant use, acidosis, low Apgar scores, you should at least do one ultrasound in the first week. Yes, these are not part of guidelines, but that's what should come in Indian setups. The ultrasound is very useful to diagnose cerebellar hemorrhage. And in 2020, the AAP also confirmed that we should always screen for mastoid for cerebellar hemorrhage. That is mandatory now. So how to identify IVH? I think you all know, but echogenic structure, oval-shaped structure, which is lateral wall, which is at the lateral wall of the lateral ventricles, which looks like a fresh echogenic structure that is in the coronal view. While in the sagittal view, which is at the caudothalamic groove, which is the inferior border of the ventricle, anterior here, where we can see the oval-shaped structure in the caudothalamic groove, that's where you can able to see the echogenic IVH in those babies. So we know that the NNF protocol just what written, we have written the team as less than 32 weeks, less than 1.5. That's where we should screen for IVH. Above 32 weeks, above 1.5, when there are abnormalities, we should think about the screening of those babies. We also know from the literature that the Papill's classification was CT scan based classification, which is a grade 1 IVH as the bleed in the general matrix, grade 2 with bleed in the ventricles without dilatation, grade 3 with ventricular dilatation, and they labeled as a grade 4 when there is a bleed into the parenchyma. But when the classification written by the Volpe, Professor Volpe, they have removed this grade 4 and there is a separate entity called as periventricular hemorrhagic infarction. Grade 1, general matrix. Grade 2, bleed in the ventricles, 10 to 50% without dilatation. Grade 3, more than 50% bleed. And grade 4, extension of the bleed and venous infarction, that's a grade 4. We know that. So just how I showed you the bleed, that's in the coronal view at the caudothalamic groove, that's a grade 1 bleed. When that bleed from the caudothalamic groove comes in the ventricles, less than 50% in the coronal and in the sagittal view, then it is a grade 2 bleed. That is presence of the blood in the ventricles, but the ventricles are not dilated, that's a grade 2. When the bleed is more than 50% in the ventricles with the ventricular dilatation, you can see the dilated ventricles, it's nothing but a grade 3 IVH. And when this grade 1 compresses these veins, when they vertical vein they compress, they produce this fan-shaped infarction, and that is called as periventricular hemorrhagic infarction. So this is, you can see the fan-shaped structures which are compressed, and these are called as a periventricular hemorrhagic infarction. So cranial ultrasound is useful for grading up IVH. Once you grade, you can do the counseling properly about outcomes of this grade 1 to periventricular hemorrhagic infarction. So the screening, monitoring, counseling is useful by point of care ultrasound. When it comes to the hydrocephalus, mainly the post-hemorrhagic hydrocephalus, you need to monitor the Levin's index. So Levin's index is from midline to the lateral wall of the lateral ventricles. These Levin's index have a chart from 28 weeks to the 42 weeks onwards. You need to remember this 97th centile as a 10, 11, 13, 28, 32, and 36 weeks. That's how simplified you remember as a 97th centile. When these indices go more than 4 millimeter of this 97th centile, 4 millimeter above the 97th centile, that means 10 plus 4, 14, 11 plus 4, 15, and the 13 plus 4, 17, These are the action line. That means the baby requires treatment. And these ultrasound monitoring helps, these indices helps in the treatment action for post-hemorrhagic hydrocephalus. These are the Levin's index with action line. Also, we can measure the anterior horn width, which is the anterior dilatation of the ventricle. We can measure the posterior part by thalamo-occipital distance. This is the thalamus, and this is our thalamo-occipital distance. We have the norms of the third ventricle also. And these norms are simplified. Ventricular index 4 millimeter above the 97th percentile, that is Levin's index. Anterior horn width more than 4 millimeter. Thalamo-occipital distance more than 26 millimeter. Third ventricle more than 3 millimeter. So all the fellows, you should keep this in mind and put these indices in your weekly ultrasound follow-up. Whenever you have a grade 2 or more IVH, you will have to do minimum weekly ultrasound. If you can do twice a week, fantastic. And measure these indices, document in the file along with your head circumference. That is most important aspect. What about PVL? PVL, we know that we have a cystic lesion into the frontoparietal occipital region by the coronal, and we can have also in the sagittal frontoparietal occipital as a cystic lesion. This is the area where we can see the cystic changes. Initially, the grading of the cystic changes is just a periventricular echogenicity, which is more than 7 days, that is grade 1. Then evolving the cyst, that's a grade 2. When the cysts are extensive, they are large enough, that's a grade 3. And when the cysts are deep white matter involving, that's a grade 4. So you can see this classic echogenicity at the frontal lesion. You can see this frontal parietal region echogenicity. This is persistent after 7 days in a 25-weeker baby. This is a grade 1 PVL. When you repeat this ultrasound after 4 to 6 weeks, you will see such cystic lesions at parieto-occipital lesion, bilateral parieto-occipital lesion involvement. This is grade 2 PVL. What is important from this one, you can predict whether there is insult antenatal. If the cystic lesions are within 2 weeks, antenatal insult. Cystic lesions after 4 to 6 weeks, postnatal insult. And you can prognosticate, we all know the outcomes of PVL into the spastic diplegias. When you see these extensive cystic lesions, you can see now the lesions are big and forming more big cysts. So these big cysts are nothing but grade 3 PVL. So this is the area what you can consider the large cyst formation in the frontoparietal occipital region is a grade 3. When these cystic lesions are involving in the deep white matter, already you are gone into the stage 4 and likely prognosis of a spastic diplegia. So you can grade the PVL by ultrasound. This is extensive. This is massive PVL. This is all areas of cystic lesions as a grade 4 PVL. You can help ultrasound brain by doing the Doppler. Anterior cerebral artery, you can measure the systolic and diastolic. Very useful in cases of asphyxia, hydrocephalus, and PDA. Very, very important. Normal RI is 0.75 plus minus 0.08. In asphyxias, RI will be low. In hydrocephalus and PDA, RI will be high, and you can actually diagnose those conditions usefully. So this is the classic baby with asphyxia where your diastolic blood flow is increased. So there is low RI. Because the diastole is increased, RI is low. And this is the classic example of reversal of flow. This is where you can see that this is absent and this is the reversal in cases of PDA or hydrocephalus. So these are the common conditions by Doppler you can able to diagnose, and you can also is useful for your pregnancy. So that's about the cranial ultrasound. This is another case of 36 weeks, baby with the severe TRZ. Pulmonary pressures are around 50, and baby has a large liver. When this baby, we have done the brain ultrasound, there was a mass. This mass, when we put a color Doppler, it was nothing but turned out to be AV malformation. So the baby presented as the failure baby, and cause turned out to be the AV malformation. Very useful for immediate identification. For the fellows, this is the article written by our team in the Journal of NNF. You can go through this in 2013. Just now, this book this point of care cranial ultrasound article written by our team and the NNF guidelines about cranial ultrasound. They are all freely available. You can go through those ones. All the material is there, which is easy to access. This is the book, Atlas of Point of Care Neonatal Cranial Ultrasound. All the pictures, near about 500 pictures are there. You can also go through this book, which is very useful for the young guns. The next case is the unregistered baby with a severe respiratory distress, prolonged capillary fill time, acidosis, increased cardiac output. Cranial ultrasound was normal. So in this baby, the baby has the distress with acidosis with increased output. And if we show you, that's the lung ultrasound, normal lung ultrasound, which are the pleural line and A lines. But in this baby, we could able to see this hepatization. And this hepatization with the shred sign is nothing but the baby with the fluid, which is a classic example of a pleural effusion. So this baby has this effusion, which effusion where you can able to diagnose by ultrasound as pneumonia with effusion. This is another case with a 35-weeker required intubation in delivery room. With severe acidosis again, echo showed severe LV dysfunction. When we are talking about the LV dysfunction, again the lung ultrasound done. And in this lung ultrasound, you saw this massive fluid. Unregistered baby with delivery room intubation, with this massive fluid. Ultimately, this fluid turned out to be, when you see such type of fluid in the lung ultrasound, and you can see the lung is floating in the fluid. This lung ultrasound helped for diagnosis. Also therapeutic tap. Tap has been done, and the tap sent, and the tap turned out to be the, where you can see that the tap turned out to be the baby's X-ray. You can see the X-ray. So that's the chylus. So this baby had basically the fluid which is related to the straw color with 100% lymphocytes, naturally required the ICD, required the FFP, and required the octreotide for treatment. So this is where the ultrasound has helped in diagnosing the pleural effusion. Therapeutic as well as diagnostic pleural effusion, this is very, very important when we consider the lung ultrasound. So what are the indications of lung ultrasound? I just mentioned that the lung ultrasound is very, very useful for diagnosing RDS, for prediction of giving surfactant therapy, for prediction of giving second dose of surfactant therapy, for lung aeration, for diagnosing TT and meconium, for pneumothorax assessment, drain insertion, for pneumonia pleural effusion diagnosis, drain insertion, for pleural effusion diagnosis and drain. So these are the classic things for point of care neonatal lung ultrasound where we can act and we can able to find out these conditions. Just in next 5 minutes, let's little bit about the lung ultrasound. So the lung ultrasound is actually the artifact produced by the pleural line. When you see that, we could use the linear probes for lung ultrasound, and these linear probes we should take at least 1, 2, and 3 images: anterior, axillary, and posterior. These 3 images are the must when you consider. The normal grayscale, you will see this pleural line and the refabrication artifacts from the pleural line. These pleural line produces the lines which are parallel horizontal. They are called as A lines. I'll show you that one. So when we talk about this lung ultrasound, the normal ultrasound, you will see the ribs, subcutaneous tissue, and intercostal spaces. Beneath that, this echogenic white line, normal, smooth, regular, hyperechoic, this is the pleural line. And below this pleural line, they are horizontal, echogenic, parallel, equidistant from each other. That's nothing but A line. A line indicates there is air in the lungs. So importance of A line, that the air is there, that air could be physiological or pathological. So this is the A line of the lung ultrasound. When you see such a perpendicular line from pleural line to the lung ultrasound surface, that is what we called as alveolar gas liquid interface. And these are the B lines. The B lines are vertical, they are laser-like, they are hyperechoic, they remove the A lines. they remove the A lines. They are not present in the normal children or adults. In newborns, they are present in the first 48 hours because the little bit fluid is there in all the newborns. So the B lines are vertical lines. They remove the A lines. B lines are laser-like. They are hyperechoic and they are present in first 24 to 48 hours in normal newborns. If the lines are vertical and they are not reaching to the end of the lung ultrasound picture, they are short, reverberate, small artifacts. They are called as cometals. So they are the one where you can see about the vertical echogenic artifacts. They resemble the same of cometal. They are called as the cometal lines. If you see these three pictures, which actually will see, these are the B lines, vertical echogenic lines. When these B lines occupy one intercostal space, this is one intercostal space, and all lines are confluent and forms one rocket. This is called as confluent B line. When there are more intercostal spaces involved, this is called as alveolar interstitial syndrome. Alveolar interstitial syndrome is the progressive form in the preterm as severe form of RDS. So we saw the B lines, we saw the confluent B lines, and we saw the multiple confluent B lines leading to the alveolar interstitial syndrome. The alveolar interstitial syndrome leading to the total whiteout lung is a common entity we see in cases of grade 3 and grade 4 RDS. So another point which will common in the lung ultrasound is called as a double lung point. So what is double lung point? In the upper lung field, you will see the pattern of the A line pattern. That means there is no fluid in the upper lung. While the lower lung field, you will see the B line pattern. And the point where there is upper and lower lung field, this point is called as the double lung point with lung sliding. The lung is sliding on those ones. So there is what we are talking is there is upper lung point and there is a lower lung, which is the B lines, upper lung is A lines. This is a classic feature of TTN. This is the classic feature. We can diagnose TTN and you don't require the surfactant. Immediately you do lung ultrasound, that's additional thing. So this is what the two important features here. There will be the synpneumonic, there is a subpleural pneumonia and whiteout lung. This is the classic picture, irregular thickening of the pleural lines. This is the classic picture of RDS. You can able to differentiate RDS. You can grade the RDS. You can think about surfactant therapy. You can think about the second dose of surfactant therapy on the basis of lung ultrasound. So it is very important that lung ultrasound helps in diagnosing, therapeutic, and finding out second dose of surfactant also. These are the patterns very useful. You can see this classic whiteout pattern. You can see this is a B pattern and A pattern. On this pattern, you require most of the time surfactant. On these patterns, you don't require surfactant. That's where the study. The lung ultrasound helps in the lung consolidation identification. The classic findings of the lung consolidation are lung looking like liver, that is called as zipatization of lung, air bronchograms, shade sign, and pleural effusion. So you can see in this picture, this is the liver and this is the lung. So liver and lung both are looking as a hard hepatized lung, that is called as hepatization. You can see the irregular boundaries below this pleural line. This is nothing but a consolidation, shade sign, and there is some little bit fluid. So this is a classic example of consolidation, and this is very useful in India for diagnosing early or late onset pneumonias. You can see now here, these are the white air bronchograms. These are air bronchogram. These are the shade sign. This is where this massive pneumonia here. This is the massive pneumonia in this baby. This is the fluid here. This fluid is a synpneumonic effusion, air bronchogram, shade sign, hepatization of lung. These are the classic findings of lung consolidation. So in cases of pneumothorax, we have absence of lung sliding. We have absence of B lines. There is a lung point is present in the pneumothorax and barcode sign. What are these ones? I'll just go through in 1 minute. So this is what we called as basically the pleura moves, the pleural line moves on the lung. So that is called as lung sliding. If there is air, there won't be the movement of these one. and that is absence of the lung sliding. The next point is called as the lung point, because there is air accumulation. At some point the air accumulation is there, and some point there is no air accumulation. Air is mainly anterior, posteriorly you don't see the air, and hence in the lung ultrasound, when there is air you will see the A pattern, when there is no air you will see the B pattern. Here there will be lung sliding absent and the lung point is there. So you can see there is a B lines here, B lines here, and there is A lines pattern. These are the lung points. So difference between double lung point and lung point, there is lung sliding present here. In the double lung point, lung sliding is always present. In the plain lung point of pneumothorax, lung sliding is absent. So you can diagnose pneumothorax by this one. So this is a classic example of pneumothorax. You can see the pattern of A line. You can see the pattern of the B line. The lung is moving here. Lung is not moving here. There is no lung sliding. There is a lung sliding, and this is lung point. And there are A lines, there are B lines. So this is a classic example of a baby with pneumothorax when the baby deteriorates suddenly. This is the way you can diagnose the babies with the lung ultrasound. There are two more signs about the lung ultrasound. One is called as the Sandy Beach sign, and second is called as the barcode sign. Normally, when you do the M mode of the lung ultrasound, upper part of the lung on the M mode will look like a beach, and the lower part will look like a sand. That's what it is called as a Sandy Beach sign. But when there is a pneumothorax, and if you put a M mode, all the lung will look like barcode, and that is what it is called as a barcode sign or a stratosphere sign. And this is the classic example of again the pneumothorax. Those who are interested, point of care lung ultrasound article written by our team, you can go through the IAP NNF book. All these points are included in that book. So point of care lung ultrasound article in that book is about well covered article for the fellows, because lung ultrasound is now DNB question. Forget about NNF fellowship or IAP fellowship. It is DNB pediatric question is there on point of care ultrasound. So you need to prepare with that question. This is the article written in NNF journal. You can also go through this article. And those who are more deeply interested, this is the book written by our team along with my professor Jan Klimek from Australia. That's a point of care neonatal lung ultrasound. So these are the books we can go through about importance about lung ultrasound. The next case is a 26-week at 800 gram. Insure, echo, PDA, given the brufen. Baby was stable till 20 days, but baby deteriorated on day 21. Abdominal distension, Billis, vomiting, apnea, bradycardia, baby required intubation. Functional echo showed high cardiac output. And that's where our team has done the gut ultrasound. And this baby's gut ultrasound shows bowel wall thinning, decreased perfusion, ascites. This is the classic portal vein gas. This is a classic portal vein gas. You can see echogenic tree-like structure. This is echogenic tree-like structure, and X-ray shows the portal vein gas with the perforation. And nematocyst, there is intramural gas. What has come out in the last 4 years? Importance of point of care gut ultrasound. Hence, those people who have started learning point of care ultrasound, they can also think about utilizing gut ultrasound by linear probe, 10 to 12 probe. Classic findings will be finding about the bowel wall thickness, finding about bowel wall perfusion, patterns of the blood flow, Y pattern, Z pattern, zebra pattern, intramural gas, ascites, portal vein gas. These are the common findings of point of care gut ultrasound in NAC. The next case, unregistered term baby with severe oligohydramnios. Intubation in delivery room, abdominal distension with large lump, echo showed severe pulmonary hypertension, severe acidosis. This baby has a bell-shaped chest on the X-ray, and the kidney ultrasound shows cystic things. Consanguinity marriage turned out to be the polycystic kidney, but that's where you are required involvement of your radiologist. So what I'm trying to say you that, dear friends, you have cranial ultrasound, you have lung ultrasound, you have gut ultrasound. Those are very, very useful. And these are the recent guidelines by the International Society about utility of POCUS in our day-to-day practice, which has been published in 2020. And these are also tells you. So what I told you about the Dr. Mohit has covered functional echo. I have told importance of cranial ultrasound, lung ultrasound, and gut ultrasound. Let's see some aspect of the lines and procedures in the next 5 minutes. When we are talking about the lines, that means confirmation of ETT, UAC, UVC position, confirmation of the PIC lines or insertion of PIC lines, and then the therapeutic taps of ascitic, pleural, and pericardial effusion, and UHG guided suprapubic aspiration and lumbar puncture. This is the area which is upcoming area, very important area. Those who are already doing brain, lung, gut, they should now move to the lines and procedures. We know that we can easily pick up the UVC position, which is low, or UVC in the heart by these ultrasounds. You can see in this one, this is a short axis view, just now Dr. Mohit has shown, and this UVC is in the LA. This is RA and this is LA. So through the PFO, UVC is in the LA. You can immediately think about removing this UVC and keeping an IVC. Here UVC is subcutaneous. So ultrasound has shown the positions of wrong UVC. You can also do the PIC line, and you can also able to identify the vessel and aorta by vessel, that means vein and artery by ultrasound. Very easy by hockey stick probe. You can put the lines, and once you have two lines, put a Doppler. The Doppler of pulsatile is naturally artery, and the hump of venous you can able to identify there is no pulsatility. And both can be easily identified by ultrasound very well. So this is the article written by our team. Point of care neonatal ultrasound, head, gut, line position, localization. Those who are interested, it's available in Indian Pediatric. Again, it's free, which is you can go through this one for lines. This is the European Society guidelines that POCUS is helpful for UVC, UAC, femoral lines, and catheters. You can see this baby. This baby's heart, apical 4-chamber view, and massive pericardial effusion. This is massive pericardial effusion. This is just 2020. I think 5 months before or 6 months before this baby. After draining, heart looks much better. So you can see the pericardial effusion diagnosis, drainage of pericardial effusion. This is after putting the line. After 4 days of the line, you can pick up, you can see the pericardial tamponade and pericardial synthesis, very useful. Pleural effusion, I have shown you, and tapping of the pleural effusion is very easy from the axial line. These are the ascites. You can also find out the vessels and just put a needle. By these ascites, you can also drain by the therapeutic ascitic drainage. Suprapubic aspiration, the most important thing when you want a good sample, suprapubic aspiration by ultrasound is very easy. This is the SAFE protocol published in 2018 about role of ultrasound when baby deteriorates. This is a SAFE-R protocol published last week. This includes additional thing. So these are the publication in European Journal of Pediatrics by Professor Daniel De Luca. You can go through these involvement of point of care ultrasound in those safe conditions. So dear friends, what we saw lung, cranial ultrasound, lung ultrasound, gut ultrasound, lines and procedure. We need more about research. I have shown you 7 to 8 articles about the research on ultrasound. We also did ultrasound and measurements of the cardiac blood flow in the HGA babies. Currently, we are doing the myocardial performance index in HGA. We are doing ventricle function in HGA. We are doing the superior blood flow in the HGAs. We are also doing ventricle function and cardiac blood flow in sepsis, and SMA and renal artery blood flow in sepsis. Some of the research ongoing in my unit. We also documented the role of functional echo in India, where we could see that the functional echo was utilized in the various modality for PDA, PPHN, and shock and line position. This is the role of functional echo in Indian setups, what we have documented. We also saw that the RI pre-transfusion and post-transfusion, this is where also we could able to find out the RI findings in the partial exchange, in the exchange transfusion and paxil transfusion. This publication is accepted. Once it is published, I'll share with you guys. This is the protocol written by us, and this is accepted by the CCPU and now the European Society of Pediatrics. Hopefully in next 3-4 months this protocol will come out. When there is a sudden collapse of the baby, what are the things we should see in the ultrasound? In the cardiac ultrasound, naturally all the structures and PDA, PPHN cardiac output. In the cranial ultrasound, find out intracerebral bleed, cerebral bleed and velocities. Lung ultrasound, pneumothorax effusion consolidation. Abdominal ultrasound, free fluid, portal and gas, bowel wall, NEC signs, line position confirmation. These are the importance when we are thinking about sudden collapse of neonate in the day-to-day practice. And once again, it's accepted in European Journal of Pediatrics. Once it is there, we'll show you guys. So dear friend, point of ultrasound is what the lecture has shown you. It's a material of last 15-20 years. It is not one day. You require initial induction, you require experience, and you require then competency. You need to have a training, accreditation, and ownership. It is a day-to-day process. The Australia has started the CCPU way back in 2007, while our Indian team, I think we have been doing, Dr. Mohit Sahni, Dr. Tushar Parikh, we have been doing these workshops since 2011, and so far so we conducted the 52 workshops. This year we have conducted the e-modules, as few of you attended these e-modules, and almost 800 delegates were there from 12 countries, and we are also conducting the online course in the last 6 months. Those who want, this lecture is available on this website for the Sono site, which is a free of cost. You can go through this lecture on the Sono site website, which is there. This is the book Dr. Mohit Sahni has just now shown, and you can contact Dr. Mohit, and Mohit has also written the name of the person where this book is available. This is the next book which is available in the next 1 month, Atlas of Neonatal Functional Echocardiography. Once it is again available, I will update you guys about the book about the functional echo also. This is a survey done by our team about the role of point of care ultrasound in Indian setups. A lot of Indian setups are using the echo and the cranial ultrasound, but we need to pick up the lung, gut, and the line position. These are the utility of the ultrasound in Indian setups. Limitations, it's mainly the operator dependent and PCP NDT. These are the two main limitations when we consider about the Indian setups. So dear friends, for us, we think ultrasound is the future stethoscope. For us, this is the most important. So this is what could be the future when we are thinking about the ultrasound. And this is a summary slide, what I wanted to tell you. Ultrasound for critical assessment for pericardial tamponade, pleural effusion, ascites, IVH, cerebral hemorrhage, pneumothorax, pneumonia. Ultrasound for screening and monitoring of IVH, PVL, hydrocephalus, PDA, PPH, and NEC. Ultrasound for procedures like pleural tap, peritoneal tap, ascitic tap, and suprapubic tap. For confirmation of the line position, UAC, UVC, ETT, PIC lines. And for research purposes, as various blood flows, SMA, and SVC. So I would say that the young ones should involve in the research now. Once you learn these things, now shift towards the research and multicentric trials, because India, we have a lot of potential. So with this, I think I'll stop here. Thank you, friends.
Thank you, Dr. Pradeep, for such an excellent lecture. I can see so many people sort of complimenting that. Both Dr. Mohit and Dr. Pradeep, just we can look at based on the number of textbooks they have contributed to, the number of sort of articles they have published, that they've done a lot of work in this area and have got great experience. And both have nicely sort of pointed out very practical points about what they should be doing on the bedside to help in sort of point of care ultrasound and functional echocardiography. I know it's 9:20. We're already sort of 9:25. We're already sort of running till late. Few discussion points. I would like Mohit and Pradeep to just take it forward. You can see that we have so many faculties attending today. You know, this just shows how important it is, and so many people would really like to get a hang of it. Uh, um, Dr. Mohit, see, what one of the practical point is when a child is on a high frequency oscillation or sometime on CPAP, it is difficult to get the standard views, isn't it?
Yeah.
And what should be doing in those cases? You know.
Uh, yeah, so this is something which is very genuinely asked. So in that case, is the best view, the best window to get the views in if you have an increased intrathoracic pressure is subcostal. Because subcostal window is a window in which you will get all the views, apical 4 chamber, 5 chamber, passing long, its short axis, everything you will get from subcostal views. So that the only then the best way to get the views is through the subcostal window.
Yeah, very nice. That's what our cardiologist also says. See, there's one window which is open for everyone. You can use the subcostal view, and you probably will get a decent information from the subcostal. But I know it's easy for someone experienced to say that, but I think you need a lot of practice to get that information.
I will just add one more thing, Dinesh.
Yeah.
What is happening? We as a neonatologist are good in apical and parasternal long and short axis. But we need to now go ahead and do subcostal and suprasternal, because these two windows are very important where you can access from below and above, and you get more information from those ones. So that's additional thing we need to learn.
See, subcostal is fine. See, always find difficult to get the suprasternal, especially in the small babies. How do you guys address that?
Okay. One important thing I would like to request here is that you get a lot of clues about abnormalities of suprasternal from your subcostal and apical chamber. Means once you have this apical or parasternal or subcostal, the commonest abnormality probably you will find is your RA-RV dilated with TRZ. Whenever you have this RA-RV dilated septal deviation, TRZ and PFO bidirectional right to left, you should be very worried and you should do proper suprasternal. Suprasternal, we also struggle, and we also find sometimes, I think Dr. Mohit can add, but you need to have a lot of practice, and definitely the positions do matter in that positions.
And this is just to, if you get difficulty, because sometimes in babies it's very difficult to get into suprasternal notch or extend the neck. So what you can do is you can keep the probe with 12 o'clock on the right subclavicular, just beside the sternum on the right side. And then you sweep the probe towards the left side. So this will give you the same view what you get in suprasternal. So this is one of the alternative window for that.
Yeah, I know. Dr. Pradeep, you talked about the lines, and I saw your paper on lines and other things. So tell me, have you got rid of X-ray after you put the lines, after you intubate the child, after you put the umbilical lines and other things? Have you stopped doing X-rays?
Okay, good question. This is the quality control project I have given to one of the IIP fellow. We have reduced 50% our X-rays. I must accept that 2015 and 2021, our X-ray has reduced for endotracheal tube position, for UVC, UAC. Not so far yet for the long line yet, because sometimes getting coiled in the groin, sometimes left side problems, but definitely reduction for ETT, UAC and UVC, that has reduced. And that is the good thing, I must say, happened probably. So I think we need to learn very simple things, nothing much more. And by training of 3 hours module, the fellows can learn that one.
See, one of the things which I find out that lung ultrasound is very sensitive in picking up pneumothoraxes.
Yes.
And it can be very sort of tricky if you try draining those pneumothoraxes based on lung ultrasound.
Okay.
So what have you both been doing? It is important to just diagnose, but you still go ahead and do an X-ray and then manage it? Or are we going to shift our practices to manage based on ultrasound? What is the message you would like to give to all because it is very important.
Yeah.
Because I have seen some of them saying, oh, on ultrasound, it's a pneumothorax. And I find it is very, very sensitive. And you might sometimes find a little bit of air, which probably would settle down. And you just leave it alone. So what are your views on that?
Okay. So the 2 points I would like to add here for this lung ultrasound pneumothorax. Whenever your baby is actually less than 30 weeker, or the baby who has very sudden deterioration, your oxygen requirement has gone definitely more than 10%, and you see there is a definite shift, and baby is not doing well on your CPAP or ventilator. Definitely that time the lung is very ultrasound is very useful. Immediately you can act. Baby just lingering there, not so bad as a very critical, or oh you feel that sometimes little bit okay, not okay, and that time lung ultrasound does show that small air. That time we don't put the needle, but first thing we do when there is a massive pneumothorax, that means increase in oxygen requirement, which is a very good guide, impaired saturation, impaired perfusion, along with this one, that time we definitely put the needle.
So if you're saying that you definitely have the lung which is not moving, or you have a lung point sign, you will go ahead and put it.
Yes.
But if you have just a very small sort of suspicious setting, you'll wait for the X-ray.
We definitely wait for X-rays.
Wait for the X-ray.
Yeah.
See, one of the things which is Dr. Mohit, people have been asking is with the neurosonogram is, see, can you pick up subarachnoid, subdural bleeds? What are the limitations, or especially with the posterior fossa, what are the limitations of your neurosonograms?
So this is especially with the posterior fossa, it is kind of issues because normal views what we take does not cover well, because for that you have to go from the AF, you have to go to the different fontanelle. So that is kind again needs expertise. So that's why from the regular AF anterior fontanelle views, the posterior fossa bleeds are very difficult to get hold of it. So that is an issue. So for that, for need to confirm with the other modalities.
But
Or
what
with
about like
special-
Pradeep, like
Yeah.
subarachnoid hemorrhages or subdural bleed?
Yeah. Extradural subarachnoid, very difficult to pick up on ultrasound. Massive subdural, you might pick up, but definitely you require more practice. Cerebellar hemorrhage, big, definitely in a baby is less than 30 weeker, very good by mastoid. If you do the mastoid behind the ears, then the cerebral bleeds, and it is now routine practice. I would urge all the fellows, along with your anterior frontal, start doing your mastoid views from tomorrow onwards. And less than 30 weeker, mastoid is mandatory. But what Dr. Dinesh has said, subarachnoid, subdural, like so you can say the posterior fossa, like sometimes dandy walkers or arachnoid malformation, very becomes difficult, but that's the area of radiologist. I think we should leave that to radiologist. Whenever you're seeing something more abnormality, involve radiologist also.
See, are there any clues like you have, like, see, there's an obvious midline shift, you probably pick it up anyhow,
Yeah.
looking for, something is happening there, let me go
Yeah.
ahead. But are there any other clues from ultrasound, neurosonogram, which will make you think, oh, there could be a subarachnoid, I should get a radiologist, or should I go for CT scan? Any other clues which will help us from the blood flow pattern or something else which will tell us?
Okay, so let's see, when we are thinking about the clues, there are two important things here. One, naturally, the clinical history is always there. A lot of time you are thinking that there is some sort of bleed, that's what you are screening. That is the first thing. That is where the baby looks pale, white out, shock, less hemoglobin, and all that. The second point in ultrasound is the massive subdural bleeds. You will see the shift of the, whether right or left shift, and you will be able to see the echogenic marking below, basically at the mid-ventricular view is very well you pick up. Whenever your mid-ventricular view, your interhemispheric fissure is not symmetrical. Interhemispheric is not symmetrical. Please try two different angles and see whether you are dealing with some additional things. What I always teach the people, if you are not getting views normally, you need to do 2 more times, and if you are not getting again, you need to think some abnormality. That means you are doing a lot of ultrasound and you are not getting your views as what you usually get. Something is there which you will need involvement.
Yeah, great. Thank you. Now, one thing is with the necrotizing enterocolitis, which is a big problem for all of us.
Yeah.
So when you have a suspicion of neck, and how good is the gut ultrasound? How reliable is?
Okay.
What are the evidence and
Yeah.
sensitivity of gut ultrasound?
So definitely there are limitations. The most important limitation is that when there is a gas comes out, then the putting the probe and the doing ultrasound of the gut becomes a problematic. But the people have started. That's what I said. Last 3-4 years, the articles are coming out on the gut ultrasound. And the most important when it comes to the sensitivity marker is basically the two things which you will be able to see is in the one which is in the right upper quadrant and one on the right lower quadrant, left lower quadrant, where you can able to pick up the gas and portal vein gas. Ascites, the nematocyst and portal vein gas. These three things are very easy to pick up. You don't require too much fancy things because by the lumbar area you can pick up ascites. By the hepatic ultrasound you can pick up portal vein gas, and any gut you can pick up the nematocyst. The problem comes bowel wall thickness, problem comes bowel wall perfusion, and the problem comes the peristalsis. These are the three things requires more practice, more involvement, and that's what I told you that that's one more project is going on in my unit about point of care gut ultrasound in sepsis, because we still struggle with those scenario. The sensitive specificity is still low. It is not universally accepted. It is not all the people are doing. They are saying, let's learn more, let's learn more. All the papers related to gut ultrasound are still from radiology department. Only 4 papers are from neonatology department.
Great. Now see how Mohit, how good is IVC in deciding sort of fluid balances, giving fluid or not? Because if you have to be so careful in giving fluid for preterm babies, so is it reliable is it age specific IVC? Whether we can make any judgment about what do you want to give message to the students?
Yeah. So the IVC is assessment is we do have the pulsatility index chart for the term babies. We don't have anything for preterm babies. But if your baby's cardiac functions are good, RV and LV functions are good, and they are not on very high positive ventilation, like high frequency or very high conventional ventilators, then it is always a reliable marker and you can decide about it. Like in many of the units in Japan, for regular IV fluids, they don't follow this 100 ml, 120 ml one. What they do is they do 12 hourly or 8 hourly IVCS measurements, and they have written for the term and preterm babies, they have written the measurement maximum and minimum size, and then they decide the fluid as per their maximum minimum size of the IVC. It is only faulty if it is your babies are on high ventilatory pressures or your RV has failed or severe PPHN. If these three things are not there, then it is very reliable. And there are charts for tables for the term babies. For preterm, it is not there yet.
So on HFV also, is it okay for to determine this thing? Is one of the questions.
No, on HFO it is not reliable because you will have high intrathoracic pressures. Then it is not reliable.
What's the probe size, Pradeep, for neck? What type of probe would you use for gut ultrasound?
The linear probes 10 to 12, or if you have hockey stick probe 10 to 18, both are good probes for the gut ultrasound.
Okay, great. So I think that was excellent, both Dr. Mohit and Dr. Pradeep. I think very informative sessions for all, and I think I see so many compliments from in the chat box and personally messages from everyone. So thank you all, and please carry on your excellent sort of journey in India of training so many people with functional echocardiography and point of care ultrasound. On behalf of National Neonatology Forum, I thank both Dr. Pradeep Suryavanshi and Dr. Mohit Sahni for sort of giving the guest lecture on this session. And I think there are no further questions. Thank you very much. Before closing, I just want both of you to just sort of give one take-home message to all the students, and then we can close it up. Mohit and
Yes,
one take-home message, please.
So the one take-home message from my side, sir, if you have machines in your unit, No matter if you're doing it wrong, just start using it. Then you will really get the stimulation to use it in the right way. So that is very important.
Don't ignore your inspection, palpation, percussion, auscultation. Clinical findings first. You should have question in your mind. You should have answer ready also. Then go to the ultrasound. Ultrasound is not the one you should start first. Always go on the clinical history. Always go on the clinical presentation. Involve cardiologist. Involve radiologist. You are not cardiologist. You are not radiologist. Be careful about those things. Very, very important. That a lot of people feel that now I know a little bit. Even small muscular waste you diagnose, involve cardiologist.
Yes, there's a great message from both of you. I think it's very important. So we are there. It just helps in assisting for management. That's what we have to remember. For making bedside decision, but we are not there to replace the radiologist or cardiologist. And clinical examination, a thorough history of the patient, and a clinical examination are still the best tool for appropriately managing the patients, and also sort of ensuring that we treat the patient, with say fluid management, anode probes, whether we put the drain, whether we put the ICD, whether we should know what to do with the neck, and very interesting like the lumbar puncture, avoiding the tap, bloody tap, especially neuromonitoring, and that is how we have to see about how well, and especially we also talk, I think we touched based on that, especially in HIEs where we can't do MRIs initially. A resistive index in the first part, first 72 hours also helps in assessing the severity about how bad is the insult to the brain. So there's different way it helps us as a clinician. Yes, clinical parameters do help, but I think ultrasound is a very good tool for all of us as neonatologists, and it's important that all of us should learn about it. There's no two thoughts about it. So again, thank you, Dr. Pradeep and Dr. Mohit. And with this, we end the cardiac module. I know each session can be, we can go on doing a lot of sessions in each but cardiology. We can have so many important topics. We have arrhythmias, we have hypertension, so many things we can talk about. But I think to cover all the topics in 1 year, it's going to be challenging. So what we're going to start from next week is, students, is going to be the neurology module. So next week we start the neurology module. So we'll soon send you all the links about this. It's about neonatal seizures management. Difficult to treat neonatal seizures. Case-based discussion is what is going to be the next NOEL session. And it is going to be Friday, because next Thursday we have a session by none other than Dr. Alan Joe from Learning from the Legends on anti-seizure steroids. So our next session, NOEL session, is going to be on Friday. Till then, thank you and good night. Thank you, Dr. Pradeep.
Good night. Good night, Dinesh.
Thank you, Vijay.